Institute in Kochi, Kerala. So with those words, I want to give the mic to sir. So sir, you can continue, sir.
Good evening, everybody, for all those here. I'm very happy to talk about something that I'm very passionate about, which is swallowing rehabilitation in head and neck cancer patients. At the outset, I definitely would like to thank Bhargav and Sriharsha for conducting this webinar. And I've also been a kind of a student or a listener for their previous webinars, and it's a great honor for me to give one. And also, a special thanks to Ratan Shetty for asking me to give this talk on this topic. Okay, so the main thing based on this talk for dysphagia rehabilitation, I thought I will just talk about certain concepts and also the lessons I've learned along the way, and hopefully this will help you in your practice. I'm assuming that the people taking part in this webinar are a mixture of ENT surgeons, head and neck surgeons, and also speech and language pathologists with special interest in dysphagia rehabilitation. So with further ado, I'll start. Oh, sorry. So Bhargav, can you see the slides? Are everybody able to see the slides?
Yes, sir. We are able to see the slides, sir. It's good.
Okay. This is the place where I work at present. But most of my foundation in learning about swallowing rehabilitation and managing patients came from these two institutions. The Royal Adelaide Hospital in Australia was where I did a lot of minimally invasive surgery training, and that's where I learned how to manage early cancers and how to rehabilitate these patients and send them home quickly. And at Amrita Institute, is a mixture of early cancers and also very advanced tumors where we include microvascular reconstruction. So this becomes a comprehensive head and neck treatment care, and that's where we have a special swallowing disorder centers. And as a team there, we learned and managed patients, head and neck cancer patients who need to improve some quality of life regarding to dysphagia. So at least 50 to 60% of the patients who have head and neck cancer suffer from some form of dysphagia or the other, and this also gets worse with post-treatment. And you know that most of the treatment, either in form of surgery, radiation, or chemotherapy, can have some adverse effects. And one of the most common adverse effects affecting quality of life for our patients is swallowing. And the swallowing, basically, the act of swallowing involves about 25 pairs of muscles. 25 pairs of muscles, that means 25 muscles on either side. And you need to coordinate all these muscles together to push that food bolus safely down to the stomach without aspirating. So it's not only one single person managing our patient, we need a whole team to manage head and neck cancer. And similarly, we need a team to manage, to help rehabilitate the head and neck cancer patients. Now, there's always a question about who is the best person to manage these patients. But from my experience, I realized it is a team. It's a team of the primary treating oncologist or the ENT surgeon and the speech and language pathologist, because if you work together, you can actually understand how exactly the patient is going to improve in his rehabilitation. Also, the important communication regarding the treatment and the tumor will be communicated both the team members. So we have actually gone from the search for a better cure rates and quality of life to the quality of cure. And I think some of the speakers in the previous webinars also talked about this. And the quality of cure is where we tend to get these patients who undergone these really toxic form of treatments to get back to the normal way of life. And one of the normal way of life is social eating. I know it's a bit difficult in this modern COVID times, but the act of eating and having a meal in public is something which we are taking for granted. And many of our head and neck cancer patients struggle with that. And it is also kind of a social stigma in certain countries for them to be dependent on tube and dependent on somebody else. Okay. So the contents of the talk would be, these are the contents of my talk. Basically, I'll be talking a little bit of physiology of swallowing, effects of the tumor on the swallowing mechanism, how do we assess and evaluate a patient with dysphagia, effect of radiation treatment on the swallowing mechanism, importance of manual lymphatic drainage and lymph That's a little bit of a new thing which is happening now in Western countries. Swallowing rehabilitation as such, which is non-surgical swallowing rehabilitation, it involves maneuvers, exercises, effect of surgery on the swallowing mechanism, and on some oncophago surgery concept. This is also a new concept which people at Amrita are working on. Okay. Physiology of deglutition. You know that, as I told you, swallowing involves almost 25 pairs of muscles, 5 to 6 major cranial nerves, and you need all these to work in coordination with the main brainstem swallowing center to have a normal, safe swallow. So So the phases of swallowing, there are basically four phases of swallowing. One is the first phase is the oral preparatory phase. That is where the bolus, the food is actually received into the mouth, mixed with saliva, masticated or grinded by all the muscles of mastication, and also the tongue, and also the buccinator muscles, which push the food. The second phase is the oral preparatory phase, where the bolus, food bolus, is actually pushed forward, pushed backwards posteriorly into the oropharynx and towards the posterior pharyngeal wall. Now, this is the most important phase of swallowing, because this is where the beginning of the involuntary reflex starts off. So you don't have voluntary control once the food reaches the part of the oropharynx. And the mucosa of oropharynx have a lot of stretch and pressure receptors, which you can sense the food and the type of food which is actually coming in. And then your brainstem, the swallowing center takes over, and then it takes over the whole act of swallowing. So the oral preparatory phase and the pharyngeal phase, when the tongue is pushed towards the pharynx, and the oropharynx as such contracts, all the muscles of the lateral oropharyngeal wall, the posterior pharyngeal wall, all contract to squeeze the bolus down to the larynx, to the posterior part of the larynx, into the cricopharynges. Sorry about that. The cricopharynges and down to the esophagus. So you have to remember there's totally 4 stages of swallowing. The first stage is of 2 components. One is oral preparatory phase, or the other is the oral propulsive phase, where the tongue is pushed back. And the second is the pharyngeal stage, which is the involuntary stage. And the third is the esophageal stage. Now, the first 2 stages, the duration of the swallow lasts for just 1 second. And the esophageal stage can last from anything between 2 seconds to sometimes between 18 seconds, as different literature says. Okay. So if you consider the whole of the aerodigestive tract in this particular picture, you can say that there are 6 valves, and this 6 series of valves, which start from the lip, the oral tongue, pharyngeal isthmus, velopharyngeal sphincter, larynx, and the cricopharyngeal sphincter. If there is a dysfunction in any of these valves, or there's incoordination between any of these valves, there could be some form of dysphagia. So if you remember that the whole aerodigestive tract is composed of 6 valves, and these are the 6 valves are 6 gates, and these gates need to open and close in coordination with perfect timing, so that the food gets safely transferred down to the stomach. So there are 2 in head and neck as such. There are 2 important things to remember when rehabilitating a head and neck cancer patient. One is the airway closure at the laryngeal entrance, and the base of tongue to the posterior pharyngeal wall contact. Okay, let's discuss about the airway closure at the laryngeal entrance. So as the food bolus gets mashed up and becomes a bolus, it comes down to the posterior part of the tongue, and the tongue pushes the food bolus as the tongue starts propulsing backwards, it pushes the epiglottis down, and it also makes 2 lateral food channels. So you would see the food bolus split into 2, and the epiglottis gets pushed down. So this is a protective mechanism where the epiglottis comes down and closes the laryngeal inlet. At the same time, you also have the closure of the true cords, false cords, and the arytenoids all coming together. So this is a 3-level closure. Now, there is some debate in literature whether how does this close, whether it's from top to bottom or bottom to top, whether it starts from the true cord up to the epiglottis or from epiglottis down. I personally feel it's from the bottom up, with the true cords close first, false cords, and then the epiglottis. The second is the base of tongue to the posterior pharyngeal wall contact. That is, when the base of the tongue propels the food backwards, it actually pushes the soft palate towards the posterior pharyngeal wall. It doesn't go up. The tongue goes posteriorly. And then this closes the whole nasopharyngeal inlet and prevents regurgitation of food. At the same time, it propels the food down with the pharyngeal. Now, there's another important part of physiology you have to know is the hyolaryngeal elevation. So this is mainly done by the supraglottic, suprahyoid muscles, which also include the extrinsic muscles of the tongue and the floor of the mouth, and all the muscles is connected superiorly to the hyoid bone. This helps in elevating the larynx upwards and forwards and anteriorly. So what happens is, when the food bolus starts coming posteriorly, the larynx gets elevated superiorly and anteriorly, and it literally gets tucked. The anterior part of the larynx gets tucked under the base of tongue, and this helps in protecting the laryngeal inlet to a certain extent. So hyolaryngeal elevation is very important, not only for head and neck cancer patients. It's very important. This particular is very important in patients who have neurological dysphagia. The only difference in patients with neurological dysphagia and head and neck dysphagia is that patients who have dysphagia due to head and neck cancers or head and neck problems, they would have aspiration, or they would aspirate the food just after they have swallowed. They would swallow, then the remaining food, either the bolus residue, which is lying there, or due to the fibrosis of the side walls, patient would actually aspirate because of loss of sensation or the residue. Whereas neurological swallowing, neurological dysphagia, patient would actually have aspiration during the swallow as such, which you would be very clearly be able to see in some of the imaging evaluations. Now, these are the subsites of head and neck where the head and neck can occur. And as long as the tumor is small, it respects certain boundaries. It will be within that particular subsite. But most of the patients who present in India with head and neck cancer, at least 60% of them end up having advanced stage cancer, and it ends up going to multiple different subsites. So we need to keep in mind when we evaluate the patient, being a surgeon or radiation oncologist or a speech and language pathologist, when we see a patient with a head and neck cancer, we need to mentally see what other structures would be affected much before they start the treatment. So the tumor could actually be, if you classify the type of tumor, it could either actually be an exophytic tumor or an infiltrative tumor. Now, exophytic tumor usually ends up proliferating and proliferating out. This would cause some kind of mechanical obstruction to the aerodigestive tract lumen and some amount of paresthesia or anesthetic sensory loss. Whereas an infiltrative type of tumor, these are a little bit more dangerous because they end up fixing that particular structure. For example, the tongue or the oropharynx, and that particular part of the structure would not move. That muscle would not move. And patient will also have pain because of the deep infiltration. And also when it goes much deeper to the muscles of mastication, they would have trismus and associated cranial nerve deficit. So by seeing the head and neck patient, you need to understand what kind of problems or what kind of rehabilitation would this patient need even before you start the treatment. This is where the planning starts happening. And also there is an extrinsic compression by certain tumors such as thyroid carcinomas, which can actually mechanically cause external compression of the esophagus. So what kind of signs and symptoms these patients present? They will have difficulty in chewing, they may have drooling, they may have nasal regurgitation. Patients with most common complaint is either they have coughing or choking or episodes or food sticking down in the back of the throat and not able to get it out. Patient will also have weight loss. So globally, these symptoms are called Murphy's trigger symptoms for dysphagia. Now we've got a patient who's had this treatment and who's complaining of his tube-dependent dysphagia. How do we evaluate? So the main thing is we do a routine medical history. Along with that, we also do a feeding history to find out what type of food that the patient can tolerate and what kind of symptoms that he has when he eats certain kinds of food. We also do a physical examination of the swallowing musculature and also a cranial nerve assessment, mainly focusing on the lower set of cranial nerves. We check on the patient's baseline respiratory status, patient's mental status and cognitive status. This is very important for rehabilitation because the patient needs to be alert. And if, for example, in a head and neck cancer patient, low sodium is a common problem. So if the patient, the patient is in the ward and he has low sodium and is a bit disoriented, you need to make sure you correct these parameters before you start rehabilitation. Then we also do bedside evaluation. That is a simplest one is a water swallow test, which is usually between 30 ml to 100 ml. And what we do is usually give the 30 ml of water to the patient if you know that if you think that he's able to drink water, and assess whether the patient has a cough or a gurgly voice. You can also auscultate because you will hear 2 swallow sounds. That's normal. And if there is a gurgle or there's a prolongation of a swallow sound, you know there is an abnormality. Another thing in a water swallow test is you can also do a baseline oxygen saturation level. You check the patient's baseline saturation at room temperature. And then when you do the water swallow test, you see whether the saturation does it drop or not. If there is a 2% dip in saturation, then there may be a problem which you need to start evaluating further. You can also, another important part of assessment is getting as much of history from the patient's carer, because they will let you know what the patient can tolerate and how long does it take to eat, and because they would be very good observant of these things. Next, we come to instrumental evaluation of the swallowing function. The most commonly done is the fiber optic endoscopic evaluation of swallowing, or FEES. The advantage of this is it's usually done with an endoscope, flexible endoscope, and the advantages of that is that it could be performed at the bedside or the outpatient clinic. You get a direct view of the patient's luminal anatomy. You see the whole of the pharynx, nasopharynx, oropharynx, and hypopharynx, and you would see also the posterior part of the oropharynx and the larynx. However, you cannot visualize the oral phase of swallowing, and there are some newer techniques to visualize that, but it's still not very much popular. And we tend to use sometimes real food in terms of different food consistencies to assess the patient's level of dysphagia. The other type of investigation is video fluoroscopy. This is, I think it's still supposed to be the gold standard of swallowing assessment because it gives a very complete picture of the whole aerodigestive tract and very easily seen in the lateral view. It is a non-invasive. You don't put any camera inside the nose. However, it needs a fluoroscopy unit, and you need a radio-opaque contrast such as barium or sometimes gastrographin to assess how the food bolus passes down. There is some amount of radiation exposure, so but then it's the benefit outweighs the risk. So you need to see which are the patients who would need video fluoroscopy. It is a little bit of a struggle when the patient cannot sit or stand straight, and the positioning becomes a problem. And also the person performing the test also does get some amount of radiation. So now we have done a FEES, or we've done a video fluoroscopy, and we have used certain scores or certain parameters to assess what the patient has or what problems the patient has. And one of the commonly used scoring systems is by Rosenbach. It's called the penetration aspiration scale, where we categorize it as 1 as no penetration, and 6 is aspiration, and 8 is very, very severe level of dysphagia. So what is penetration? Penetration is when the food bolus or the contrast enters the airway, but it remains above the vocal folds, mostly the true vocal cords, and there is no residue. So when you have the patient swallow a food bolus and you have a look at the whole luminal anatomy, or you see in the video fluoroscopy, the food bolus just comes over the airway and then moves down or disappears. So that's penetration. Whereas when the food bolus or contrast passes down into the glottis, and sometimes goes down into the subglottis, goes through the clots, then it's aspiration. We also use the functional oral intake scale, where we can assess the level at which the patient is, whether the patient needs to be nibbled by mouth or he can take an unrestricted oral diet. During during my time, the short time in working with dysphagic patients, I went through many different scales. There are lots of scales available, and you can see it in the literature, from dysphagia severity scale to performance status scale. And the most latest scale that we are using right now is the, sorry, I don't have that, the digest scale that is right here. Basically, it's of two components. It is the it assesses the penetration aspiration score, and it combines it with the pharyngeal residue. That's the amount of residue of food or contrast in the aerodigestive tract. And then you have a kind of a template where you can, once you score the patient, you see at which level the patient, what grade of dysphagia that the patient has. So it's categorized into 4, into mild, moderate, severe, and life-threatening dysphagia. Now, impact of chemoradiation on swallowing. Mainly what happens is that patient has decreased movement of the base of tongue towards the posterior pharyngeal wall. There's reduced laryngeal elevation, and there's reduced pharyngeal contraction. There's long time for the food bolus to go down, and there's delay in initiation of the swallow. Some people cannot start the swallow, and there's incomplete or inadequate opening of the upper esophageal sphincter. Now, you will not find all this in the same patient. You may have bits of each of these signs with varying severity, our patients who underwent radiation. So that's why most of our radiation oncologists make sure they focus and try to protect the dysphagia aspiration related structures, which are basically all the constrictor muscles, which you can see in the scan here, the superior, middle, and the inferior constrictors. The inferior constrictors are divided into 2, the thyropharyngeus and the crycopharyngeus, and also the true and the false vocal cords and the esophagus. So they try to make sure if the tumor is not near any of these structures, they try to reduce the dose in that area to preserve the swallowing function. So why do they want to do that? Because this is an important slide. Radiation-associated dysphagia is pretty common, like what I said. And what happens is post-radiation patients do get some amount of lymphedema or radiation-related edema of the airway. And it's an initial phase. It's an acute edema. It'll be just that. But sometimes what happens is this edema stays there, and it tends to become fibrosis. There's deposition of fibroblast and collagen tissue, and this swollen tissue stays like that. And because of chronic fibrin deposition and chronic inflammation at that area, the sensory nerves, or the main nerves that supply the sensation of the inner part of the larynx and the pharynx, start getting de-innervated. And this chronic. So what happens is, because of fibrosis, because of de-innervation, patient progresses from an acute edema stage to late fibrotic, insensate aerodigestive tract, or the larynx and pharynx, and patient cannot feel the bolus of food going backwards, and not able to have that pharyngeal squeeze that food bolus down into the esophagus. And this is what ends up making them tube dependent on some form of feeding tube. So this is an interesting fact. It's in one of the papers I had read that in patients with primary tumors of the oropharynx who undergo radiation, above 7 to 31% develop chronic aspiration. Imagine around 30 out of 100 people develop chronic aspiration. I don't if they have a radiation to the, but this is just one single paper saying that 11% develop aspiration pneumonia and 4% are chronically feeding tube dependent after chemoradiation. Whereas cancers of larynx or hypopharynx, about 22 to 30% develop chronic aspiration, and 5% are chronically feeding tube dependent. So these people really need a lot of help, a lot of motivation, a lot of input from our side to help them to get back to their normal life and not regret having the kind of treatment they've had for their cancer. What we want to avoid is these two, whether be it a ward or in the OP. On the screen on the left side is silent aspiration, and the image on the other is the secondary aspiration. Silent aspiration is what I said, as in radiation-associated dysphagia. Patient has no sensation and no supraglottic sensation, no posterior pharyngeal wall or lateral pharyngeal wall sensation. So you can see he just easily aspirates, and he's not coughing. He doesn't cough at all. You can see the patient doesn't move around, cough. Whereas you see on the right-hand side of the screen, secondary aspiration, patient is swallowed, and there is a little bit of a stricture or a difficulty for the whole bolus to pass down completely. And what happened, because of some stasis, it spills over into the larynx, and you can see the patient starts to cough. So these are the things we don't want to avoid in our ward or in a clinic, because patient would end up being dependent on a feeding tube and keep making recurrent visits to the medical or pulmonology team for signs pneumonia. And if patient is chronically dependent on a nasogastric tube, what happens is you end up getting an indentation of the nasogastric tube on the posterior part of the cricoid cartilage and the arytenoids. And there is also mucosal damage, and the posterior cricoarytenoid muscle gets necrosed. So invariably, the patient gets a dysfunctional larynx, and he or she needs to undergo laryngectomy. So, a note on lymphatic pathways. This is very important, and it has been slowly gaining more importance in the recent times. Overall, you can just say that there are three type of lymphatic drainage pathway: the anterior, lateral, and posterior drainage pathways. And what happens is, post-radiation and post-surgery with adjuvant radiation treatment, patient do get some amount of lymphedema. And so what happens is, if this external lymphedema, which is actually subcutaneous, and if it's prolonged, the same thing happens. Radiation-associated damage happens on the skin and the neck also. What happens? There's a lot of fibrous tissue, a lot of adipose tissue deposition, and it prevents this movement of the muscles of the neck, especially with regard to hyolaryngeal elevation. So patients have a very stiff, woody neck, and when a patient has external lymphedema, they also have some form of internal lymphedema. So internally, when you do an endoscopy for these patients, you'll find that they have really boggy looking larynx and really edematous larynx, and sometimes these the arytenoids don't move at all. And very prolonged duration, these cricoarytenoid joint gets scarred and fibrosed and fixed, and that's the end of that, because after that patient, whatever you do, nothing works. And finally, you end up pushing the patient for a salvage surgery. So this is what I'm really concerned about, because once the patient finishes radiation treatment, I want to catch them and make sure they start their rehabilitation. They should be starting rehabilitation before treatment, but they should continue or really step up their rehabilitation exercises and therapy within the first 6 months after treatment, be it surgery with radiation or radiation alone. And constant movement of the larynx and pharynx will help shift this fluid out and also help in increased oxygen deposition and reduce fibrosis. There are many studies which substantiate what I've just said, and they've also researching on the role of manual lymphatic drainage for external lymphedema, and they feel that when they do manual lymphatic drainage for external lymphedema, the internal lymphedema also reduces, and this helps to overcome and improve or reduce the level of dysphagia in some patients. So coming to swallowing rehabilitation, dysphagia rehabilitation, it's of two types. One is a rehabilitative or indirect swallowing therapy, wherein over here no food is given. What we do is we have a set of exercises and maneuvers to strengthen the muscles which have been weakened due to the treatment, and try to improve the stamina of these muscles and try to get them back to normal. Compensatory or direct swallowing therapy, over here some amount of food is given. There is some damage to the existing musculature or existing digestive mechanism. So what we do is we bypass that by using the intact musculature and try to compensate, have compensative exercise maneuvers, and try to help these patients to swallow. And we do that by giving different types of food consistency diet. There is an international dysphagia standardization diet initiative where you go according to a graded level of, when you're rehabilitating these patients, we go with different levels of food consistency, starting from thin liquids to thick liquids, and from pureed or liquid food to regular food. Now, coming to effect of surgery on swallowing mechanism, I'll start telling about each of the head neck subsites and what problems you can anticipate when you have patients going through a surgery. So if the patient undergoes some surgery on the lip or the anterior part of the buccal mucosa, or if the patient undergoes a lip split incision, sometimes the marginal mandibular nerve can be sectioned, and that leads to weakness of that particular part of the lower lip. And this creates some poor approximation of the orbicularis, especially in terms of lip split incisions. If you don't close these the orbicularis muscle and reapproximate properly, they would have some lag in weakness of that particular lower lip. And also, if the mental nerve is cut, there will be loss of sensation. So patient would actually have anterior spillage while eating, and that's not very nice to watch, especially in a social setting. And they're always a bit embarrassed when they have a leakage of food anteriorly. You can see over there anterior spillage in the video fluoroscopy. When we take the buccinator muscle out along with the buccal mucosa resection, even during reconstruction, there's a loss of the normal vestibule. The function of the buccinator is usually used to push the food towards the teeth. If the food starts going laterally into the cheek, the buccinators push the food towards the teeth and help to grind the teeth. The food gets ground by the teeth and then goes to the tongue. So that gets affected. So one type of rehabilitative exercise is the button pull exercise, where you put a button with a twine and keep it in the gingivolabial sulcus and try to form a seal around the button and try to pull that button against resistance. This is just to try to strengthen the orbicularis oris muscle. If the patient had a cancer of the buccal mucosa of the lip and then had a reconstruction, and if there is if he has macrostomia, that's a large mouth, then commissuroplasty would help in some form to narrow the opening and help to have a good seal. You can see in this particular patient, he had a large flap put in, but however, he had a macrostomia and is dribbling saliva. And once they had an appropriate commissuroplasty surgery, and he was able to drink without any spillage. There are also sometimes when the flap does not heal or does not set according to the way we want, and if there is a part of bone which is also taken along with it, as in marginal mandibulectomy, the part of the reconstructed flap tends to collapse inwards into the oral cavity, and that is a bit of a problem. So sometimes a prosthodontist, if the patient has teeth, the prosthodontist could help to fix some kind of prosthetic to complete this defect and help prevent some of the spillage of the food. For tongue cancers, if it's a very small lesion on the lateral tongue, the patient does not have much swallowing dysfunction, and usually it is left to heal by secondary intention. There would be a simple deviation of tongue, and beside the patient would be fine. But if the cancer starts involving more than half the tongue, of oral tongue, that is, then a patient would need some form of reconstruction. And if the flap which is put there is really tight, that ends up becoming like an anchor holding the remaining tongue down, and the patient really struggles to swallow. So we would actually be wondering, patient has enough oral tongue on the other side, why is he not swallowing? That's because he cannot have, he's not able to do the propulsive action, because the flap, which is not adequate enough in terms of length, in terms of width, is anchoring the anterior tongue down and preventing from doing the propulsive posterior action. Patients will also have some difficulty in articulation. Okay. So these are some of the reasons for dysphagia in tongue cancer patients: is inadequate tongue control. They cannot chew on that side because their tongue would normally helps to push the food between the teeth and try to push the food backwards, so that action would be gone. There's delayed oral transit time. That is the whole act of chewing and swallowing from food passing from the oral cavity to the pharynx is going to get prolonged. There's going to be some oral residue, because on that part of the tongue which is resected, there is no muscle, and there would be a pocket. So that will cause some amount of residue. Inadequate laryngeal elevation. This usually happens when tongue with some floor of mouth muscles are also taken out. This I'll come to the later slides. Large retrolingual space. If you see here in this video fluoroscopy picture, you could see that there is a huge gap between the whatever remaining tongue and the posterior pharyngeal wall. Normally, it should be just less than 1.5 centimeter. So this is the retrolingual space. If there is a large space, the food is not being propelled adequately posteriorly backwards to the cricopharyngeal sphincter. Coming to floor of mouth, most of the time advanced tongue cancers, we end up resecting in the floor of mouth, and there will be loss of glossoalveolar sulcus and also tethering of the anterior tongue, which I already spoke to you about. What we want to avoid is this anti-gum deformity if we have to take out the middle 1/3 of the mandible. In that situation, what you see here is the patient, this particular person does not have a middle 1/3 of the mandible. So the tongue is actually prolapsed backwards, and there is no anterior support for the floor of mouth. And over here, you can see with the reconstructed flap and a good hyoid suspension, patient can actually swallow, and the retrolingual space is also less. So tongue and floor of mouth during the resections sometimes involve suprahyoid muscles. So so that has a lot of disability to swallow. So during this situation, even though you do a very good reconstruction, you put a lot of bulk, patients still struggle to swallow. So we can try some compensatory maneuvers such as head back, where the patient tilts the head back and tries to swallow and uses some amount of gravity to propel the food back. Anyway, they would not be able to eat solid food, chew on the solid food, so they would be restricted to a semi-solid, to a puree type of diet. I'll come to another slide later on, but this is the hyoid suspension I was talking about. When the surgery involves resecting most of the ventral tongue and the floor of the mouth, especially the middle 1/3 of the mandible, we really need to reconstruct that and also do a hyoid suspension where the larynx hyoid is suspended to the mandible. And you can see after the hyoid suspension how well the laryngeal elevation is. And there's no aspiration with this patient. There is also, in terms of glossectomy, people at Amrita have actually done functional reconstruction, where they've used the gastromental flap, 2 free flaps, gastromental and a gracilis muscle flap, where they motorize the muscle flap and try to recreate the propulsive action of the tongue. And this patient, you can see the picture on the left side video, is one who had a total glossectomy. But what is actually moving the neo-tongue is actually a part of the muscle, the gracilis muscle and the stomach flap. And he's been living for 10 years on a soft to semi-solid diet. Coming to the mandible, as I told you, the patient who undergoes a mandibulectomy, there is loss of dentition, sometimes malocclusion when the teeth don't align properly and the patient cannot chew into the food and or bite into the food. If it is lateral mandibulectomy, they don't have that much of a problem. But if it's an anterior mandibulectomy or involving the middle 1/3 of the mandible, patient would have a lot of problems regarding swallowing, and they may end up being a swallowing cripple and dependent on tubes, tracheostomy and feeding tube. Patients don't have that much dysphagia for a marginal mandibulectomy. However, as I told you before, anterior marginal mandibulectomy, they would have some loss of oral sphincter control and drooling of saliva. So in these situations, we try to use compensatory maneuvers such as head tilt, where we ask the patient to tilt and try to swallow tilt the head towards the normal or the unaffected side or untreated, non-treated side and try to swallow. And that usually helps them until they get back their, they get adapted. And some people find their own way to swallow. Hard palate. One thing I've learned in dysphagia management is that when you take the two main bones for the oral cavity, that's the maxilla and the mandible is more important than the maxilla because the mandible houses all the important suprahyoid muscles, tongue muscles, everything else. The maxilla is just there to give a correct approximation to the mandible. So patient who undergoes a maxillectomy, the problems you'll face is there would be a loss of oronasal separation. That means the oral cavity and nasal cavity would be one single chamber, and patient would have more problems with speech and some amount of nasal regurgitation. And in these situations, prosthetics helps. We can also do a flap in front of it just to create that oronasal separation, and also add teeth to help with the chewing. Trismus. Patients with trismus in India, submucous fibrosis is very common, and these patients have very limited mouth opening, and that can cause a lot of issues with trying to eat different types of food consistencies. So trismus management is a whole entity by itself, and sometimes prior treatment itself, we need to start rehabilitating these patients for trismus. And if regular rehabilitation doesn't help, then coronoidectomy, that is to release the temporalis muscle, and might help in opening up the jaw. Sometimes we resect out the fibrous tissue, which can cause the trismus, as in this patient, and then you can do a nice flap which covers the whole area once you get the adequate mouth opening. So here's a patient who had very severe trismus and very good mouth opening, almost 3.5 centimeters post treatment. For oropharyngeal cancers, previously surgery involved, even if it's a moderate stage, surgery involved a mandibulotomy approach, where you actually split open the mandible like a book, and you end up resecting or splitting all the floor of mouth structures to reach that particular part of the oropharynx, whether it be the tonsil or the base of tongue. This creates a lot of morbidity in terms of prolonged hospital stay and also getting relieved of the feeding tube. However, recently, with the advent of the minimally invasive surgeries like the laser, the robotic surgery, the morbidity of mandibulotomy is very much reduced. So we don't do mandibulotomy approach unless it's a really, really big advanced tumor. So what problems can they face? If it's a tonsillar cancer and patient has had surgery for that tonsillar cancer, there would be decreased mobility of that lateral pharyngeal wall because there's nothing there. It's just usually when you do a tonsil resection, whether it's a robotic or a open approach, the superior constrictor on that part is taken off. So what would be there would be a dynamic insensate flap, which should not move, it's adynamic, or sometimes when we do a robotic surgery, you'll allow that area to heal by secondary intention. So that part of the lateral wall of pharyngeal wall will not move. It will be like a solid wall. Whereas tongue base, there would be, if the resection involves more than 50% of the tongue base, then there will be definitely loss of laryngeal protection. Patient has high chance of aspiration, and the propulsive action of the tongue is also gone. Soft palate, there's a lots of the oropharyngeal suction pump, and also patient have velopharyngeal insufficiency. This is mainly the negative pressures created as the food passes down into the pharynx, and that will be disrupted when operating on the soft palate. This is actually a patient who had an adenoid cystic carcinoma of the tongue base, where robotic surgery is done, and also a free flap was inserted, and patient had near normal swallowing on the 6th post-operative day. So that's how minimally invasive surgery helps. Along with that, you need to rehabilitate patients too. So patients who have undergone radiation treatment, they end up not using the tongue for a long time, for almost 6 weeks. They might end up eating for some time, and due to severe mucositis, pain, fibrosis, they will not, their swallow would be very restricted and end up losing weight and onto a feeding tube. So in these kind of patients, we advise them tongue hole maneuver. That is, you try to hold the tongue between your teeth, or the Masako maneuver it's called. Try to hold the tongue between the teeth and try to do a dry swallow. Try to get the tongue between the teeth and try to do a dry swallow, and also stretch the tongue out as far as you can, and try to, this is basically working on the base of tongue. The other option is a Mendelssohn maneuver, where you actually recreate the hyolaryngeal elevation by manually elevating the larynx and trying to get them to eat some form of food consistency. This is after checking whether the laryngeal function is intact. You can also do a lingual protrusion against resistance. Like I said, try to use a tongue depressor within tongue depressor, and to keep pushing that and forward, back, posteriorly and laterally, and trying to do different movements to strengthen the tongue. This way, creating doing a dry swallow. The Masada technique again is illustrated much better. You can see the tongue being held between the teeth, and you try to keep the tongue in that place and try to swallow. So you're just focusing swallowing the saliva just with the base of tongue. For patients who underwent resection or high radiation treatment to the soft palate, and a part of the soft palate doesn't function, they end up having nasal regurgitation. During that time, we can advise them a nose pinch maneuver, and this maneuver is basically to pinch the nose when they try to swallow a bolus, and this will increase the negative pressure, suction pressure, to get the food down to the cricopharynges. I know that this maneuver cannot be done for a long time because the patient gets frustrated doing this for every single bolus. The other alternative is a good secondary reconstruction, or sometimes a palatal obturator that closes up the gap there. For tonsil, a lateral oropharyngeal wall, I told you that that part of the tonsillar wall or the lateral oropharyngeal wall would not move. Hence, we need to use a form of compensatory type of exercise. Rehabilitative exercise by strengthening the rest of the constrictor muscles. And that one way of doing that is the effortful swallow, where you keep the food bolus in your mouth and really try to squeeze that bolus down, and using all your energy and focus just to push that bolus down by using the rest of the muscles. Shaker exercises, when you treat the oropharynx or any other primary site, head neck site, you also treat the neck. So patients will have some weakness of the neck muscles and indirectly the hyoid. So shaker exercises help in strengthening the supra-hyoid and infrahyoid muscles. Then the patient, usually we advise them to lie flat, supine, and try to lift the head up and look at the tips of the toes and hold that pose for almost 10 seconds, and then put the head back down. An alternative to Shakir exercises is the chin tuck against resistance. This is done by some of our colleagues in Southeast Asia. Basically, they use a ball to use a rubber ball as a resistance to practice that. And the advantage of this as compared to Shakir exercises is that you can tell the patient to practice it anywhere in the house. He doesn't need a bed to lie down. He can just sit up and then keep strengthening the suprahyoid muscles. An alternative to that is there are many different gadgets which have come. This is, I think, a phagoflexia. Flexophagia. This is a kind of a gadget where you fix it to a table, or you can hold it and then do the same kind of chin tuck against resistance exercise, mainly to strengthen the suprahyoid muscles. Coming to larynx, surgeries such as partial laryngectomies. For example, if a patient underwent a vertical partial laryngectomy, that part of the hemilarynx is is fixed. There's no moving vocal cord there. And if a patient had a horizontal semilaryngectomy or a supraglottic or a supracricoid laryngectomy, they would lose two primary protective anatomical structures of the airway. One is the epiglottis and some part of the aryepiglottic fold and some false cords. So it is very imperative that you would be hearing a little more about this in the talk tomorrow. Basically, the patient who undergoes for these type of surgeries must be very, very motivated. That means when you say motivated, they should be actually prepared to undergo or prepared to go through these adverse effects of these surgeries. That is, patient would have high chance of aspiration, and so they need to be very motivated to get rehabilitated and overcome these problems and the anatomical deficit. If you actually see, this is one of the first supraglottic laryngectomy done with the robot. So over here, we had to take out of the supraglottis, but what I did was to preserve one part of the one cricopharyngeal joint and also the superior laryngeal neurovascular pedicle, which may not be very seen clearly there. But patient took a long time to, this is actually a primary surgery, and patient still took almost 2 to 3 months to get back to an almost near normal swallow. And he was tracheostomy dependent for a while, and also we ended up putting a peg tube, but he was so motivated to get back, and within the few months we were able to decannulate him. So the crux of these partial laryngeal surgeries, being a speech and language pathologist or a primary surgeon, you need to find out from the operative notes which structure is taken out and which is preserved. So this will help you to work and tailor make the rehabilitative exercises for these type of patients. So the most common exercise which we advise them for these patients, even before the treatment, is the supraglottic swallow or the super supraglottic swallow. This entails basically holding the breath, having a swallow, and then coughing after the swallow. Whereas super supraglottis involves that patient not only holding the breath, but also trying to really bear down. And supraglottic elderly people are more understand how to do super supraglottic swallow more easily than a supraglottic swallow. So you take the food bolus in the mouth, hold your breath, bear down, swallow, and then cough, and again swallow. So that's the supraglottic swallow. Coming to the hypopharynx, surgery in the hypopharynx is usually not routinely done, but there are a few centers doing primary surgery. And what problems they get is there is scarring of the lateral hypopharyngeal wall. There could be injury to the superior laryngeal nerve, thereby having loss of sensation to that part of the hypopharynx. If a post-cricoid tumor, there could be a stricture or some form of narrowing. And if it's a circumferential tumor, then patient would have almost sometimes stenosis. Posterior pharyngeal wall. Not many people know this, but when there is a tumor of the posterior pharyngeal wall, and especially in the middle of the posterior pharyngeal wall, when it depends, you need to figure out how the depth of these tumors are. If these tumors are very deep, and going all the way down to the superior constrictor, then the patient is going to have a lot of swallowing dysfunction. If it's a superficial problem, a superficial tumor, then any minimally invasive approach would help, and patient can get back to normal eating. So the most common problem in regard to surgeries, usually patient undergoes salvage surgeries for hypopharyngeal tumor. They've already undergone radiation treatment, and the fistula, pharyngocutaneous fistulas are very common. And one of the ways to minimize these fistulas is to when they do a reconstruction, they use a salivary bypass tube. So what happens is that the saliva is channeled into this tube and not around the anastomosis site, and that way minimize the risk of a pharyngocutaneous fistula. The problem with these pharyngocutaneous fistulas, what I've seen is that when the patient has pharyngocutaneous fistula, it takes it usually heals by scarring at second intention. And then the patient starts getting recurrent strictures at that area where it's healed. And that's another ongoing problem which we see in the rehabilitative side. So if a patient has undergone radiation for hypopharyngeal cancer, and so what maneuvers we try is the head turn maneuver, where we ask the patient to turn the head towards the opposite side and then swallow. So you channel the food bolus down to the normal or the opposite side and get them to swallow. Because the other side would usually be fixed or immobile. Chin tuck also helps in these to help with the hyoid laryngeal elevation and opening of the crycopharyngeal sphincter. So you can advise Shakir exercise and Mendelssohn maneuver. Now, patients who undergone total laryngectomy, you might think that they would not have any problem swallowing, but they also have a lot of swallowing problems, mainly because of three reasons, which I have seen. One is that when the surgeon takes out the larynx and then resutures the constrictors, infraconstrictor back, there these constrictors are not in line with each other. So there is a lot of coordination between these constrictors. And when the patient tries to swallow, he needs multiple swallows. Sometimes they end up having a pseudo-epiglottis or a false vallicula over that. So food gets pocketed there. There's also some theory about a lower resting pressure in that reconstructed pharyngoesophageal segment. So that food does not go, there is always a delay in transit. It starts going a bit slowly until it goes down to the esophagus. The other problem is when the patient has a speech valve or a speaking valve, they always, if the healing is not good around that area, they would have a leak around the valve or sometimes through the valve, causing some amount of dysphagia and aspiration, and then they end up getting the tube back in again. Skull base, most of the tumors which affect the anterior and the middle skull base, the lower cranial nerves tend to involve the lower cranial nerves. And if the trigeminal nerve is involved, or if the resection is around that area of the branch of the trigeminal nerve, patient will have some weakness of the masticatory muscles and also impaired oral preparation. Facial nerve, of course, they would have drooling, weakness of that side of the face. Glossopharyngeal and vagus nerve, basically the pharyngeal reflex or the gag reflex is impaired. Patient will have nasal regurgitation because of the soft palate, as we talked about before. And also patient will have a weak voice due to a vocal cord palsy or paralysis and leading to aspiration. If there's a hypoglossal nerve palsy, there's impaired oral preparation on that particular side and also propulsion of the food because of the atrophy of the tongue muscle. Patients with tracheostomy, patients still have some amount of aspiration when they do have a tracheostomy. This is mainly because they also have some amount of dysphagia because they are not able to maintain that subglottic pressure, which is needed for a swallow. So when we actually, I showed in the beginning of the video, in the beginning, the larynx where the vocal cords close together, come together, and the epiglottis closes out the laryngeal inlet. So when there is a positive subglottic pressure in a normal person, the vocal cords remain closed and really tight, and they're on the same plane. So that helps prevent any form of liquid or any form of liquid food bolus to go. If it spills over into the laryngeal inlet, if it has a penetration, it won't end up as an aspiration because of the subglottic pressure. But patients with tracheostomy will not have that. They cannot generate the subglottic air pressure because there is a tracheostomy tube and it bypasses the larynx there. And because of prolonged tracheostomy, they'll have loss of sensation of the supraglottis and also reduced hyolaryngeal movement, especially if the scarring and fibrosis of the occurs around the strap muscles. So patients with tracheostomy also have dysphagia. Sometimes the tracheostomy tube is put for dysphagia, but also sometimes makes it worse. And in rehabilitation, it also worsens or prolongs our rehabilitation. And ideally, we want to get them off the tracheostomy tube. Now, there is a randomized controlled study studying on electrical neuromuscular stimulation for head and neck cancer patients and how it helps patients with rehabilitating patient with dysphagia. Apparently, they found no change or no improvement with using electrode neuromuscular stimulation. However, this is a bit of a controversy because there are other papers which suggest that electrode neuromuscular stimulation works. And so they are researching on that, and I'll explain in another 2 slides. But when do you start swallowing rehabilitation, or when do you start rehabilitation? There is no specific time to start, like saying this is the time you need to start. Swallowing rehabilitation or the thought about rehabilitating these patients starts when the moment you start evaluating the patient for treatment. And hence, there are a lot of papers on prophylactic swallowing exercise or Faringo size, where they feel that patients benefit and have reduced chance of getting dependent on tube when they start exercises before radiation treatment. And normally we start the prophylactic swallowing exercise at least 2 to 3 weeks before radiation therapy starts, and then encourage the patient to keep continuing doing these exercises during the radiation treatment, and try to postpone the insertion of the nasogastric tube. And suppose that the patient is losing weight and is getting very severe mucositis, then we stop doing any more swallowing exercise. Wait until 2 weeks after radiation and then start again. But prophylactic swallowing exercises, many centers have started doing that, and they show that there is a good improvement, and many studies are there showing that it works. With regard to electrical stimulation, the head and neck team and swallowing rehabilitation team at the Keck School of Medicine, they had come up with a microstimulator. This is a very small implant which is implanted along the hypoglossal nerve. This, by radio frequency, this keeps stimulating the hypoglossal nerve to keep stimulating the tongue and the suprahyoid muscles. This is usually, the implant is still in experimental or research stage. This implant is inserted before it starts radiation treatment, and during the radiation, the stimulation is continued throughout the radiation treatment, and then it's removed many months afterwards. So the concept is that the constant stimulation of these suprahyoid muscles help in preventing atrophy and fibrosis of the swallowing musculature. Coming to physiology, I think Bhargav, excuse me, sorry, can I take another 10 minutes? Is that okay? Or
yes, sir, absolutely. There are no webinars, so still 1 hour is there for you.
Okay, so I'll maybe 10-15 minutes. That's it.
Yeah,
so,
sure, sir, sure.
So now the patient has been treated well. Is basically cured of his cancer, and he's getting rehabilitated by a speech and language pathologist. He's been assessed, and all these exercises have been given. But unfortunately, he's not able to reach that particular goal, that particular level where he wants to be, and he's still struggling doing non-surgical rehabilitation. And this is where we introduce the concept of phago surgery or oncophago surgery. Basically, it demands a careful interplay of knowledge and surgical expertise of a head and neck surgical oncologist, laryngologist, and a reconstructive surgeon. This is basically to augment the swallowing function and also help rehab the patient even further to get free of the feeding tubes. And this is not regular swallow therapy or swallowing exercise maneuvers rehabilitation goes hand in hand with oncophago surgery. So there are a few cases which I thought I'll discuss about where we've applied these principles for our patients and had some pretty good results. So one of the common problems we encounter is a crycophobic dysfunction, where unlike neurological swallowing problem, the cricopharyngeus ends up becoming a bit stiff, inflamed, and because of the inflammation, it becomes very hypertonic. And normally the cricopharyngeal muscle is in a state of tonic contraction. It only opens comes at that point. So it's like a sphincter, right? So, but in some patients, it becomes more hypertonic. Maybe the vagus or the pharyngeal plexus get irritated, or there's a reflux. Patient also has associated reflux esophagitis, and also to do with some neuropathy or aging. So with these patients, when non-surgical rehabilitation does not show any improvement, we've tried Botox. And this is a 70-year-old gentleman who had a nasopharyngeal cancer who was irradiated. And after radiation, he was PEG tube dependent for a long time. He also had a prior stroke many years before his radiation treatment. And on video fluoroscopy, we found that not only patient we thought maybe strictly he may have a component of a cricopharyngeal spasm. So we thought we'll give a try of Botox, and you could see that Botox being injected. This is his video fluoroscopy picture before Botox, where you can see a lot of residue, not much, very little amount of food bolus is going down. He has had 2 episodes of aspiration pneumonia, and he's a very potential at risk at having secondary aspiration, because anytime this could spill over. After Botox, you can see him. There is still a little bit of residue here and there. That's mainly because of the radiation fibrosis, and he needs to build that up. We've not been eating for a long time, but you can see that the food bolus goes down very smoothly. If Botox doesn't work, then we could try Crycophobic Myotomy. That is either this is in the form of either a laser, minimally assisted, or robotic assisted. Open Crycophobic Myotomy has been tried, but a little bit, these patients already undergone radiation, chemotherapy. So the wound healing, when you open up all the planes, a little bit resistant to doing that. Sorry, I'll just go back. Yeah. Here's a patient of a Faringo tracheal fistula. Basically, this is I think a 60-year-old lady who had thyroid cancer, who had radioiodine ablation, breast cancer, and during one of the routine gastroendoscopic procedures, she also had a history of a pre-malignant lesion of the esophagus. So during the routine gastroscopy, she had a iatrogenic perforation, and she ended up with a retropharyngeal abscess. And you can see she was tube dependent, tracheostomy tube, and PEG tube dependent when we saw her, and we could also see the retropharyngeal space, but all the abscess is healed out, but she could not swallow. And on evaluation, we found that she had recurrent coughing whenever she had something, and we found that there was a tract which was going from the pharynx down the posterior pharyngeal wall and going down all the way into the trachea. You can see her aspirating into the lungs. Over here, you can see that. So there was a fistulous tract between the posterior pharyngeal wall, the piriform fossa down to the posterior pharyngeal prevertebral space and the trachea. Piriform fossa, prevertebral space down to trachea. So under general anesthesia, we identified the fistulous tract, and we resected the fistulous tract, and then we primarily closed the mucosa and reinforced both ends of the fistula with strap muscle and sternocleidomastoid muscle flaps. The reason why these patients, I feel it comes under the name of oncophago surgery, is that not many would, unless you have some amount of experience in managing head and neck cancer patient, and also some idea about how the functions of the larynx and pharynx, and communicating with your speech and language pathologist, you would not be able to venture and do these surgeries because you need to have a good knowledge and expertise of managing these patients post-operatively. So this is post-surgery. You can see the fistulous tract is all closed and the patient is swallowing. There's no aspiration and no spillover into the larynx or trachea. And you can see a bit of the strap muscle flap over there. It's like a finger protected over there. Okay, Lotic insufficiency. This usually happens when patient has a skull base resection or a thyroidectomy and damage to the recurrent nerve, or sometimes even a cervical spine surgery for some vertebral metastasis. And in these patients, this is very similar to a phonosurgery or a laryngeal medialization surgery, where we inject fat into the paralyzed portion of the vocal cord to bulk it up and hopefully medialize this cord, and this prevents aspiration. These patients, we try different type of maneuvers, like a supraglottic or head turn maneuver, but some of them, the glottic gap is so big that you need to do something. You need to go and intervene and help augment that swallowing function. That's big. This is the video of pre-injection. You can see the large posterior glottic gap. Most of these patients end up having a large posterior glottic gap, and so they're able to take solid foods, but they will not be when they take liquid or water. And this is post medialization or glottic insufficiency. And this is a pharyngeal stricture where a patient who's had a total laryngectomy and a reconstruction with a supraclavicular flap. But you can see that she has stricture at the anastomosis site, and where she's really trying hard to swallow. And you can see how the neopharynx balloons out like that. And when we made her turn her head to one particular side, you could see a trickle of the barium going down, contrast going down. So she was really, really struggling. Her quality of life was very much affected, and no amount of rehabilitation or exercises. We were a bit stumped to wondering what to do. So finally, we had to go back, open up, resect the stricture, and do a gastric pull-up. That helped with the swallowing, and she had a very comfortable quality of life. And this is her function post-op. Okay, so there is a recent paper by Professor Dr. Sinha who basically published on self-esophageal dilatation for head and neck cancer patients. These are instead of patients waiting to go see the gastroenterologist and or coming to us for the surgeons for a dilatation for their strictures, they can perform these self-esophageal dilatation at home with using these specific Mallory dilators, Mahoney dilators. Only thing is that prior to, we need to really assess these patients with dysphagia and due to stricture and find out how the stricture is. If the stricture is an hourglass shape, they can try the dilators. But if it is, if there's a chink or if it's a deviated type of stricture, deviated one side, it's very difficult to put the dilator and dilators. So this needs to be done under endoscopic guidance. So you need to assess, and I think this would be, we can, once the patient is able to get hands on some kind of a esophageal dilators, then we can propagate self-esophageal dilatation. So to summarize, swallowing problems after head and neck cancer treatment are dependent mainly on the extent of resection, the nature of reconstruction, and the specific structures radiated. And beyond that, it also depends among our Indian patients the extent of the tumor as such, because most of them present the advanced stage tumors. So the global function on that particular side of the tumor is usually affected. There are different methods of treatment for various dysphagia, but our final aim is to make the patient totally independent of the feeding tube and thereby improve their quality of life. And it is everybody's, I think, basic right to eat. And if you actually, we actually swallow, normally we swallow 35 times an hour. We swallow our saliva 35 times an hour. While sleep, we swallow 6 times an hour. And imagine a patient who cannot swallow, who's struggling with swallowing his own saliva, how his emotional and his quality of life would be. So when the treatment involves the tongue base or arytenoid cartilages, whether being it radiation or surgery, there's always a high risk of aspiration. So we need to keep in mind, we need to tailor make the rehabilitation for these particular patients, and we need to keep dysphagia, see for signs of dysphagia in these patients. Besides surgery, post-operative radiation has an additional negative impact on swallowing function, because not only surgery, along with radiation, there's increased fibrosis of the head and neck radiated tissue, and maybe surgical management. If non-surgical rehabilitation doesn't help, surgical management can help to augment the swallowing function. I would like to acknowledge some of my mentors and colleagues because everything we do in head and neck is a team-based, and most of these people have learned from or worked with and understood swallowing rehabilitation besides just managing head and neck cancers. Thank you so much.
Thank you, sir. Thank you for the great presentation. There are multiple things, multiple questions in the chat box.
Okay.
Before we go into the questions, I have few announcements to make, sir.
Okay.
Just in case if someone is having any problems, I am redirecting them to my Facebook page where the streaming is present. The second thing, there is one questionnaire for dysphagia management by Ms. Rekha from Master CMI, which is in the chat box. Everyone can go through it. The third thing, I have put up Dr. Vidhyadharan sir's number in the chat box. So if you have any issues, you can contact him, and he has already displayed his email there. So you can either contact him there too. So with those words, Can we take the questions now, sir?
Yeah, sure.
Yeah. So our first question is, what is the difference between modified barium swallow and normal barium swallow?
Modified barium swallow is a dynamic swallow, so you can actually see the whole act of swallowing. Whereas a regular barium swallow is just a pictures. You just take a photograph, and the problem is that you tend to miss small, minute aspirations. You can still use regular barium swallow to rule out aspiration, but you will miss these small, minute aspirations on how they happens. So modified barium swallow assesses the whole dynamic function of the swallow.
Okay, thank you, sir. So our next question is by Mr. Srikanth. A patient with midline lesion in tongue or mandible, how do we manage dysphagia in such patients? Post-op tracheostomy patients who have dysphagia to manage.
Is it
I
oral
think his
tongue?
question is patients with midline lesions in tongue or mandible. How do we manage dysphagia in them?
So it depends on what treatment they've had. If it's oral tongue, they would have surgery. And if it's involving mandible, definitely the ideal according to NCCN guidelines would be surgery. But if it is a posterior tongue, then the patient would have radiation. So it depends on how that is gone. Because if it's an oral tongue, patient would have surgery and the type of reconstruction. If they had anything in the middle of in the mouth, that is if you are taking this part of the mandible, you need to have a bony reconstruction or at least a plate, so that where the tongue is actually anchored to the plate or the bone, and this helps with the posterior movement of the tongue. If you is free floating, the tongue would fall back. The patient will always be tracheostomy dependent. So it depends on which treatment they've undergone. But most of the time, if it's a base of tongue, you need to strengthen that part of tongue because they have radiation therapy there.
Okay, so our next question is by Ms. Rekha. For VFS, when to use barium sulfate and when to use gastrographin?
So this from there's always a little bit of a controversy in this, me talking to other people. But what we do, I used to do Namrata, and what I do right now is that if I suspect barium is more harmful to soft tissues than the lung. Barium is more harmful to soft tissue than the lung. So I use barium when I know that there is no Faringo fistula. If there is a Faringo fistula, then I would try with gastrographin, because I feel gastrographin is more harmful to the lung. Barium is more harmful to the soft tissue. So this is the way I go about it. Sorry, Bhargav, I cannot hear you.
Sorry, sir. The next question is by again Ms. Rekha. Can urographin be used instead of gastrographin?
Urographin, I think it's the same. I think, or I'm not quite sure about that. But maybe your radiologist will be able to tell you that. But I think it is the same.
Okay, sir. Next question is by Dr. Harsh Dhar. Role of placing hyomental stitch after major glossectomy. I think he meant total glossectomy. Does it actually help in improving hyolaryngeal elevation?
So you should not. It helps. It depends on two things. From what I have seen, is that you not only have to take it through the hyoid, you need to go down and take the larynx, the cartilage of the larynx also, and you need to bolster that area so that you don't cut through the larynx cartilage. So you need to mentum, hyoid, and larynx, and you need to reduce that size, the gap, interval gap, make it as less as possible. So if you're a surgeon, you need to remove the neck extension, try to flex the neck and get that narrow that hyomental distance.
Okay, sir. Thank you. So the next question is by Dr. Sarita. Type of swallowing rehabilitation in patient with total glossectomies.
Patient total glossectomy. So one thing you need to remember is that a patient with no tongue will not be able to chew really solid food, because you will not be able to do this. You will not be able to move the tongue between your teeth. You don't have a tongue. The tongue which they recreate will not move in between your teeth, try to get the food from the side of your mouth into that. So they will not be able to eat solid food, unless they have some kind of assistance where with their finger they need to push it around. They can swallow if the larynx is intact and functioning is good. They can swallow liquid and semi-solid suit. So we usually teach them supraglottic swallow, that is to voluntarily close the larynx, protect the larynx, and then try to swallow. And sometimes this head back position helps because that uses gravity to push the food back.
Okay, thank you, sir. So next question by Dr. Deepthi Patel. In case of central arch dissections, if reconstruction plates are not used, how to perform hyoid suspension?
If there's no reconstruction plate, then and there is no bone, then it's the patient will be, as I told you, that he'll have an anti-gump deformity. So they won't have even the propulsion movement of tongue. They won't have the hyolaryngeal elevation. So you need some kind of a bony, some kind of a hard structure there to attach the tongue and the larynx. So if there's nothing there, patient will be actually drooling saliva and he'll be tracheostomy dependent because he can't initiate any swallow. And anything you give would cause some form of aspiration, and he can only maybe eat just for taste or some kind of comfort, just for taste. So what we can do with these patients is try to use a syringe with a small tube, which I think I missed that slide, but to push the food backward. You use a syringe and push the food posteriorly, place the food and try to get them to swallow. But this is not a normal way of swallowing. This is just for taste or some kind of pleasure in eating some food. That's all. They'll still be tube dependent for routine. So you need a bony, some kind of reconstruction here.
Thank you, sir. Next question is a little contemporary question, sir, by Ms. Aishwarya. How to manage swallowing rehabilitation during conditions like COVID-19?
So I think a lot of our speech and language pathologists will be able to answer because they have become masters in teleconsultation, telemedicine. And that's coming up quite a lot because most of them, some of them I've spoken to in Chennai, they're doing a lot of teleconsultation. So you don't have to actually see the patient, but instrumental evaluation is going to be a problem. Maybe and even me, I'm not doing a fees routinely in all patients. If I do have to do a fees, because swallowing problem, dysphagia is not an emergency. So if I really have to do a baseline swallow or something, I do a full PPE. You have to have all the personal protective equipment, and also your endoscopes need to be sterilized the same way how you do for HIV or hepatitis B patient. That's what we will be following.
Next question is by swallowing rehabilitation after TORS for base of tongue and open partial laryngectomy.
Yeah, so I think the speaker tomorrow will be speaking a bit more also on this. But the thing is that what I learned was that you need to really start the swallowing rehabilitation as soon as possible. That is day 2 or 3 after surgery. Post-op day 2 or 3. Either try with some ice chips, either try with some little bit of water, and then start speeding up because we need to start this before the fibrosis set in. The edema will reduce over the first 24 to 72 hours. But swallowing rehabilitation should start commencing at least the post-op day 3. And if it's any midline structure that has been taken off, post-op day 3 it should start. If it's just a lateral structure, post-op day 1, you can start swallowing rehabilitation.
Okay, sir. Sir, I'm clumping 3-4 people's question to one question. So what maneuver to teach a patient undergoing primary RTCT or CRT for a head and neck malignancy?
Okay.
Like in general head and neck malignancies.
So
mostly base of tongue, oropharyngeal and laryngeal lesions.
Yeah, that's right. So if all the midline structures, what Bhargav you told, base of tongue, larynx, and posterior crycopharyngeus, post-cricoid, all the midline structures, you need to strengthen all of them. So again, tongue, strengthening the base of tongue, laryngeal elevation, and also any maneuver to open up the crycopharyngeus. And keep in mind that all patients are not the same. Everybody treated like an individual, like how you treat the cancer also, because each one has a different level of motivation, different level of stamina, different level of emotional stability, all that happens. So you need to take everything into consideration. That's why we start them before the treatment itself. And they're most patients are very motivated just before the treatment. And during the treatment, it fluctuates. So you catch them there. That's why I feel speech and language pathologists should be a part of the tumor board, because they need to, they should be there to decide, okay, this patient I need to catch before they go into surgery or radiation, and start that. And you need to keep communicating with your primary the head neck surgeon or whoever, ENT doctor, and so that you can work together.
Okay, sir. I definitely agree with your point that speech and language pathologists should be included in our tumor board. Yeah, that's a good thing. So our next question is, what's the time period to start direct and indirect swallowing exercises?
So it depends. Again, if you know that, so direct or indirect is compensatory or rehabilitative. If you know which structures are being taken out or really being, having dysfunction, those are the patients you need to do a compensatory. So compensatory usually happens during treatment or just after treatment. Rehabilitation, if you take radiation, compensatory will start sometime during treatment and or before treatment. You teach them the exercises, let them continue that during treatment, and continue as much as possible after treatment. And once the 2 to 3 weeks after radiation, completion of radiation treatment, you can start the rehabilitative treatment to strengthen the rest of the muscles all around. Because until that time, that area would be receiving a large dose of radiation. It would be painful for them to move and also strengthen that muscle. Whereas surgery, you wait until the primary surgeon is happy for you to start any rehabilitation. So that's the main thing. The surgeon should be happy because he knows where he put the stitches. He knows what structure is taken. That's why it's important as a team. You need to sit and read the operative notes to figure out what you can work with and what is missing, what structures. That's the thing.
So our next question is by Miss Akanksha Anya. What is the cause of reverse peristalsis and how can we rehabilitate such patients?
Reverse peristalsis, if it's an esophagus, if it's related to head and it's very rare that it could be due to head neck cancer treatment unless they have a stricture. If they have a stricture below and the esophagus, the peristalsis happens, the first, second, third peristalsis starts coming, and it's not able to, food is not able to pass through a stricture, there's going to be a regurgitation of food up. Okay. But if there's a hidden neurological problem, some kind of esophageal spasm or nutcracker esophagus or some kind of achalasia there, then gastro doctors also have to be involved and need to figure out what exactly is the problem, because they will have some kind of a medical treatment for that. I hope that answers your question.
Yeah, yes, sir. So again, another question by Akanksha Anya. In case of patients undergoing radiotherapy, when do you recommend to remove the tracheostomy tube, keeping in view the safety of swallowing, if breathing is not the concern? I think aspiration is not the concern is what she meant.
Aspiration, yeah. So yeah. The thing is that the sooner you remove the tracheostomy tube, the better is for three things. One is good for you because they don't keep coming back to you for tracheostomy tube blocks. Second is that patient is happy that the tube is out, he can talk. And third is that the patient you can raise patient on that particular thing, because tracheostomy will not hinder. So when do you remove the tracheostomy tube is when, how I do it is that I would sometimes before doing a FEES, I'll do a laryngoscopy. I would examine the whole larynx. I would see each part of the mucosal structure, or each subsite of the larynx and pharynx to see if they have good sensation there, and if there's good movement, and if they have very good cough reflex. So if all these three things are there, good sensation, good movement, and good cough reflex, then I know that patient can protect his larynx. So and protect his lungs, because he will not aspirate. So then, but you cannot remove the tracheostomy tube immediately, because most of the time, if they have long-term tracheostomy tube, that part of the tracheal segment can get a little bit weak, so it can collapse inward. So you need to slowly decannulate, get them to a small speaking tube, downsize the tube, and then cork the tube, and then take the tube out.
Okay, sir. Sir, one more question by Akanksha. How can we rehabilitate patient with secondary aspiration and woody neck? It's a good question.
So this is what I'm talking about. So if it is many months down treatment, post treatment, this is a challenge which I face, because the neck is really hard. Nothing moves. You don't even know what's moving, and usually there could be some stricture or fibrosis over there. So the patient needs a lot of motivation. You need to keep pushing But I usually keep a threshold for a few months. Maybe I'll tell the patient and the bystanders that, look, we will going to do the rehabilitation for like a period of 6 months, and we're going to do initially it'll be like use it or lose it kind of rehabilitation, because it depends on the level of the baseline function what he has right now. If the patient is completely stiff neck, nothing moves, tracheostomy dependent, no sensation, full saliva, dysfunctional larynx, you cannot do anything. I guess the only other option would be a possibility, maybe a laryngectomy. We might have to slowly, counsel them and get them that side. But if you feel there is some amount of food passing through on VFS and he has some movement there and he's also equally motivated, you can give a threshold for 6 months, like a boot camp therapy, really push him for all types of rehabilitation, strengthening exercises, and see how it goes. If you start seeing improvement every 3-4 weeks, then you know that, start decannulating the patient. Once you start decannulating the patient, there'll be a big jump in his swallowing function also. So it all depends on that, how many months post-treatment.
There are a couple of questions from Dr. Chaudhary Satyanarayana. First question is, that's not that clear, sir. Can we perform a transoral harmonic myotomy? He did not mention for which structure.
I think maybe for the tongue, I think.
Yeah, I think the second question, I think we can understand. Does use of harmonic surgical resection if tumors given adequate margin and better outcomes for tongue and oropharyngeal tumors?
So
I think you want to know about harmonic scalpel in surgeries and rehabilitation.
One thing I've learned in all these years is all these instruments are just a cutting tool, and it's the person who uses it that's what matters. So whether you use a laser or a cautery or a knife or a harmonic, it doesn't matter as long as you get a good tumor margin. As a head and neck surgeon, you take out the tumor off, but the healing, if it's going to be a big defect, the reconstruction matters. The type of reconstruction matters. You've seen in the previous few talks. But if it's a very small defect, it doesn't matter whether it's laser, cautery, or even a harmonic. So I don't think it makes a big difference. And if you think loss of sensation, all this will come back. They would have edema around the nerve, and that particular area, there would be some loss of sensation, but they will return back in 6 weeks' time.
Okay, another question by Dr. Chaudhary Satyanarayana. Is salivary gland preservation protocol in radiation help?
Yes, definitely. Because of the advent of IMRT, you would see a lot of studies showing that they have improved swallowing function, and now proton therapy is coming too, and they're doing quality of life studies on that. So saliva serves as a lubricant, as an antiseptic, as an enzyme, a degradation of food. So the lubricant factor of the saliva helps in movement of the bolus of food as such. So salivary gland preservation really helps.
Okay. Next question is by the name is not given. Whether we can have any objective cutoff value of PAS beyond which a partial laryngectomy should be contraindicated.
So you're saying that pre-treatment you want to assess the function. I think if a patient's already aspirating before the surgery, he will be tending to aspirate even more after the surgery. So that patient itself may not be a good candidate for that particular surgery. You might learn a bit more tomorrow. Most of these patients who undergo partial laryngeal surgery needs to have a very good lung function. And if you have constant aspiration, constant aspirant pneumonia, you're not a good candidate for partial laryngeal surgeries. So you need. So if you already have aspiration or signs of penetration in that area, but if the tumor is very small, okay, you can give it a try. But if they're already aspirating, then I think they may not be a good candidate for a partial laryngeal surgery.
Okay. So next question is by Meet Sethi. Any tips to avoid inadequate endoscopic crycopharyngeal myotomy while avoiding perforation?
So what I have learned is that I should see the Bhargaw Faringo fascia. That once you go down the mucosa, you cut, you will go through the muscle layer, and this is where you need to go layer by layer, and you would see the shiny the Faringo fascia there, and that's when you stop. You don't go beyond that. and preferably go in the midline in the posterior most part, nothing on the laterally if it's endoscopically. If you're going to do open crycopharyngeal myotomy, I think you need to go one of the sides. But endoscopically, it will be midline.
Okay, sir. Another question again by Dr. Meet Sethi. What questionnaire do you use to score dysphagia?
Right now we are using a digest score. Previously, we were using the performance severity score. Right now, the digest score is I think it's by, I'm not sure, I forgot the author's name, but the digest score. If you Google the DIGEST score, you would get the paper.
Sure. Our next question is by Dr. Mohan. He's asking for rehabilitation exercise in vocal cord palsy.
Yeah, so the most common thing, the side of the palsy, for swallowing for dysphagia, you need to turn to the your head to the affected side. Okay, you need to turn the head to the side of the palsy side. Okay? So what will happen is that you close off that piriform fossa, and you get and if you're having good approximation of the opposite cord, compensatory action of the opposite cord, when you turn the head to the opposite, to the side of the cancer, you close that piriform fossa, and all the food gets channeled down to the normal piriform fossa, and then you swallow. But if you want voice, it's the other way. You have to turn the head the other way. So for swallowing, it's turning to the affected side.
Our next question is by Dr. Shubhra Sharma. Any new updates in FEES assessment, FEES assessment, or any new article which you recommend to read?
I have not come across an article, Dean. I'm looking for it, but there is Dr. Jayakumar Menon usually talks about OFEES, oral fees, and also the goose. Basically, they put instead of putting the flexible endoscope through the nose, they have a kind of a mouth gag, and they put the tube the camera into the mouth, so they see the oral face also, and also the pharyngeal face. So it's called OFEES. But I've not seen any videos, and I've not seen this performed in any of the conferences I've attended. So I'm also keeping a lookout for it.
Okay, thank you, sir. Our last question by Dr. Mohan. Indications for Ryle tube insertion in post-RT or neurological conditions?
If I take it again, three things. One is that if I see frank aspiration and more than 1 or 2 episodes of aspiration, either video fluoroscopy or during FEES, I think it's not safe. One single aspiration during the investigation is okay. Patient was not ready at that time to swallow, and so many people are telling you so many things. So at that time when you swallow, the second thing, if you feel the patient is losing weight and he's becoming very weak, so he needs the tube for nutritional support, and he's not able to eat enough through mouth, normal through oral intake. The third thing is, if the patient is undergoing radiation, you need to discuss with the radiation colleague to see what do they feel. Do they feel that comfortable, or do they feel that his level of general nutritional status is helpful for their management? Because you cannot stop radiation or chemotherapy in the middle of the treatment. So you need to keep it going. So you need to keep his nutrition and weight up to the recommended expected level.
Okay, sir. Another question has just come in by Dr. Jomol Jose. Any recommendation to improve cough reflex?
Any recommendation in all head and neck cancer patients improve?
I guess so, sir. He has just posted this much.
Our cough reflex as such
I think he's directing to post-RT setting.
Post-RT setting, okay. See, if you have a good sensation of the larynx, definitely patient will cough well. If immediate post-RT for larynx or post-RT for hypopharynx, there will be some amount of edema. They may not have that great sensation, but they have good tracheal sensation. Then you need to get these patients to do supraglottic swallow, supraglottic swallow. That involves a cough. So voluntarily trying to cough. And also, this is where the physiotherapist also comes in, because you can increase the expiratory muscle stamina and their muscle strength to help, to really get a deep cough from your diaphragm out. So these are the things we can do. But The reflex as such, I don't know how I'm still not sure how I'm going to get it activated as such. He should have good sensation to cough it out. That's the thing. The lung function, diaphragm function, we can keep improving and help them to cough better.
So that's it, sir. These are the questions till now. And I thank you very much, sir. Thank you very much for giving us the opportunity to talk.
Thank you very much. And it was a good, great honor, and I hope everybody understood something.
Absolutely, sir. Absolutely. It was very informative. Okay. So with those words, I want to take leave with this one, sir.
Thank you. Thanks a lot. Good night, everybody.